Noreen Womack. I'm a pediatrician with the St. Luke's School-based mobile clinic.
Hey, Casey Knudson. I'm a child and adolescent psychiatrist at St. Luke's Children's, and I work in both Nampa and Boise. Well, we're excited to do this. This is going to be a two-part series, so hopefully you don't get too sick of listening to me over the next couple of sessions, but lots of important stuff to talk about, and we really do try to hone it in and keep it somewhat focused. And so the way that we'll present today is I will spend time talking about a myriad of mental health conditions, and then Dr. Womack's going to help fill in some gaps with some small case presentations throughout so that we can try to keep it relevant and focused as much as we can. Next slide, please. So the goals of today is for us to review what we call the DSM criteria. DSM stands for the Diagnostic Statistical Manual, and so that's the manual that we use as psychiatrists to diagnose various mental health conditions. And we're going to be looking specifically today at depression and anxiety and ADHD and ODD or oppositional defiant disorder, as well as disruptive mood dysregulation disorder. We'll review some cases that illustrate common presentations of the above disorders, particularly as they might present in a school setting, and then discuss some management strategies for school personnel at the very end today. Next slide, please. So to dive in, we're going to start with ADHD. And the reason I chose that one to be the first topic is because ADHD is something that we see very frequently in the schools. And I feel like it's a little bit more quote unquote in your face than other conditions or disorders, because especially those hyperactive kids, they're bouncing off the walls, are really easily identifiable, and it's pretty distinguished. But there's a few different ways that ADHD can present. Primary things are that they might struggle with focus and concentration. They may be easily distracted. They might be fidgety, restless, or even sometimes disruptive. I always like to talk about this when we're talking about various mental health disorders, but the question always of what constitutes a diagnosable disorder. So meaning what is the difference between somebody who might struggle a little bit with focus and attention and somebody who actually meets criteria for a diagnosis of ADHD or frankly any other mental health disorder. So there has to be two things. The first is that there needs to be distress. And so when we're talking about distress in the realm of ADHD, it might be that they're failing classes, that there's disruptions in the classroom where teachers are emailing parents or calling parents and saying, hey, your kiddo's really causing problems in school, or they might be even struggling with relationships or friendships. And then the second part of that is that there has to be impairment. And that kind of comes back to that failing classes as well. The distress would be the kid saying, I'm really struggling with this, the impairment piece, the actual result. What we know is that a little over 10% or 11.4% of children ages 3 to 17 have been diagnosed with ADHD. That data is a little bit outdated, but pretty close. And I would say that those numbers are probably a little bit higher today. Boys tend to be diagnosed with ADHD more than girls. And we'll get into the primary reason behind that in a few slides. Next slide, please. So when we look at diagnostic criteria, this is a lot of information. And so I'm not going to read this to you verbatim because that just gets boring and a little bit redundant. But a few things that I think are important is that there has to be a persistent pattern of inattention or hyperactivity or both. And so on this first slide, it's looking at various criteria related to inattention. And so there's 9 of them listed here. Kids need to meet criteria for at least 6 in order for them to be diagnosed. If it's older individuals, they only have to meet 5. But for children that we're seeing in the school setting, they need to meet criteria for at least 6, and it needs to be present for at least 6 months. When we're talking about symptoms of inattention, it's things like failure to complete tasks, not listening to instructions, rushing through work just in an effort to say that it's complete, problems with organization, problems with getting easily distracted or being forgetful, losing, misplacing things. So those are some of the common things we might see. Next slide. And then over to the hyperactivity or impulsivity piece, again, 9 criteria. They need to meet 6 in order for it to be consistent with a positive symptom. This is going to be the most common complaint is going to be fidgeting, that shaking of the leg repeatedly, or constantly like moving their hands. They might have a difficult time staying in their seats, kids climbing on top of chairs, talking to their hears, cutting in line, blurting out answers, having a difficult time waiting their turn. These are the kids that we might more classically like be like, boom, we know that kid has ADHD because they're all over the place. Next slide, please. And so based on these symptoms, as I already mentioned, there's three different types. There's the combined type. They have to meet criteria for both. So 6 inattentive, 6 hyperactive, or there's hyperactive type or inattentive type. Where this difference in percentages between boys and girls comes from is that biological boys often have hyperactive type more commonly than biological girls. And so hyperactive type is picked out of the crowd almost right away. So these boys in kindergarten, first grade, second grade are being diagnosed because they are very disruptive to the class. More girls have inattentive type, which they tend to be called spacey or just their minds in the clouds, and it gets missed way more often. I would argue those numbers are actually probably pretty similar between biological boys and biological girls, but I think biological girls are more often missed because they more often present as inattentive, not hyperactive. Next slide.
All right, so this is me. This is our first case. This is a 6-year-old male that I saw in the Boise School District. And this young man, he was in kindergarten and he was referred by a teacher. And they actually referred to me in the first few weeks of school. So it was like school had just started, and then the next week he was referred to my clinic. And I actually asked the parent and teacher to uh, reschedule for a few months later because he had not ever been in any kind of formal instruction, no preschool, no childcare before. And some of those kids just need some time to learn how to sit still in circle time, to learn how to adjust to transitions from recess or lunch back into the classroom, taking turns, sharing, etc. So I actually ended up seeing him closer to like end of October. And the reason why he was referred to me mainly was because of bullying. But when you ask those follow-up questions about, okay, what is he actually doing? So what he was doing was to his friends. He had a few friends. If they weren't paying attention to him, he would get a bit of a running start, um, grab them, hug them, and then half the time they'd end up like being on the floor. But if you don't understand the intention of what he's trying to do, it looked like he was tackling kids all the time. But when you talk to them, and the teacher who really knew him well said, he's just trying to get attention from his friends. So there wasn't that bullying power dynamic there. They weren't victims necessarily. So that really was like what he was doing. That was the impetus for his behavior, was just getting attention. Um, in my exam room, he was that kid that Dr. Knudson mentioned, who's the young boy who literally was bouncing off the walls. He could not sit still. He tried. You could see in his face. He was trying to please sit still so I can talk to your mom. And after, I don't know, a minute, his favorite sentence was, "I'm bored." And so he would wander around the room. He played with, my stethoscope. He jumped off the exam room table, etc. And apparently, this is what was happening at home and what was happening in school. And if anybody has ever sat in a kindergarten classroom for more than an hour, you know that these sorts of behaviors are not uncommon for any of those 5 and 6-year-olds that are in there. But what distinguished this kiddo was that he was doing this all day long, every day, and it hadn't improved even over like the few months that he was in kindergarten. Next slide. So this is a screenshot of his Vanderbilt questionnaire. So typically we'll give a Vanderbilt questionnaire to both the parent and the teacher. They're a little bit different. We're looking at the teacher one here. The left is the front of the questionnaire, and on the right is the back. And unfortunately, I cut off the numbers of the questions on the left there, but the first 18 symptoms or questions that are asked on this questionnaire are taken straight from the diagnostic criteria that Dr. Knudson just showed you on a few slides before. So, meaning the first 9 questions are all the symptoms or the diagnostic criteria for ADHD inattentive type. So if you look at it, let's see, number 1 is fails to give attention. There's also difficulty sustaining attention, not following through, difficulty organizing tasks, etc. So the first 9 are the diagnostic criteria for inattentive type. Questions 10 through 18 that starts with fidgets with hands or feet. I don't know, it's pretty small. I don't know if y'all can read that. Oh, thank you for the cursor. Leaves seat, runs around, difficulty playing in quiet activities, acts like he or she's driven by a motor, talks excessively. So those next 9 questions are the diagnostic criteria for ADHD hyperactive type. So when you look on the right column above, it says never, occasionally, often, very often. So to be significant, you have to score an often or a very often, the 2 or the 3. So, for instance, in the first 9 for the inattentive symptoms, if you score a 2 or a 3 on at least 6, like Dr. Knudson mentioned, at least 6 of those criteria out of the 9, that's considered significant. So, in our friend, he was significant for 9 out of the 9 for the inattentive type. And then when you look at questions 10 through 18, you do see that there's a few number 1s, but the rest, the teacher circled 2s or 3s, which again, that's significant for hyperactivity. So in this case, he met criteria for ADHD combined type since he had at least 6 of the 9 for each of those 2 categories. You can see that there are more than 18 questions. And one of the reasons that we clinicians like the Vanderbilt is because it acknowledges that there's a lot of overlap in symptomatology between the mental health diagnoses, right? So there are other things that can look like ADHD, and we're going to talk a little bit more about some of those things a bit later. But anxiety and depression and oppositional defiant disorder. So those are some of the things that the Vanderbilt tries to capture too. And then the last thing I'm going to point out on this scan is that on the right, where it says there's a subsection called performance. And so Dr. Knudson mentioned that you can't just have the symptoms, they have to be causing distress and or dysfunction or impairment in that child's life. And for this questionnaire, if a teacher or a parent say that in any of these areas, for instance, reading, relationship with peers, following directions, if it's considered either somewhat of a problem, which is a number 4, or problematic, a number 5, at least one of those, then that is considered impairment. So this child with the teacher Vanderbilt does meet criteria for ADHD combined type with impairment. Next slide. Typically, we see these children twice. So the first visit was the history and physical, getting that diagnostic interview, handing out the Vanderbilts to the parent and teacher. And then we see them back and follow up to discuss the findings of the questionnaires. You do need both parent and teacher information. You can't diagnose ADHD with impairment just in one arena of a child's life because children spend time at home and at school. Those are the main areas where they spend their time, and you have to have these symptoms be pervasive in both of those areas, home and school. So you need both the teacher and the parent Vanderbilt back. So in the case of this young man, we did go over the diagnosis of ADHD combined type. And we did start a few things, including medication. So he got started on Concerta, but more importantly, we started him in some counseling, occupational therapy, and behavioral consultants. So when we involve a behavioral consultant for a child with ADHD, it's really for their family because a lot of their success depends on the family understanding what ADHD is and isn't. In making that child as successful as possible. For this kiddo, I mean, he would take a shower and he would come out of the shower, he'd still have shampoo in his hair. So the behavioral consultant helped the family make a picture list that was tacked up to the side of the shower so that he knew, okay, after you shampoo your hair, you actually have to rinse your hair before you get out of the shower, things like that. The things that were really making the parents frustrated, they put all these picture lists around their house, and it really improved everybody's distress. And gave the child some success too, because he could see that the parents weren't as, upset at him all the time. And then the last note about this guy, again, children have short attention spans. Children are physically active. They're supposed to be, but it's really that pervasiveness, and the impairment and distress that lead to the diagnosis. Next slide.
Thank you, Dr. Womack. That was a great case and great presentation. Appreciate that. Um, Now we're going to transition over to oppositional defiant disorder. And the reason I like to do this immediately after ADHD is because this is something that oftentimes co-occurs or can be diagnosed in conjunction with ADHD. Um, when we're talking about oppositional defiant disorder, there are really kind of three areas of focus. One is angry and irritable mood. A second one is argumentative or more like that defiant type classic behavior. And then the final one is vindictiveness. And when we're talking about vindictiveness, I like to put a small definition in there, but it's a desire to get back at someone. So like if they're holding grudges or they seek revenge towards people, that's considered vindictive. Um, for a child or an adolescent to qualify for a diagnosis, again, there has to be that distress. And then there has to be impairment in functioning, usually in an academic or social setting. Um, and a lot of times this disruption is impacts their ability to perform well in school, to make friends, and they can also sometimes put them in really kind of harmful or unsafe situations. Next slide. Um, Again, that first bullet is just re-emphasizing what I was saying before, the point of impairment and functional impairment and distress. When kids are younger than 5, we want this to occur on most days for a period of at least 6 months. And if they're older than 5, then we say that it should occur at least once per week for 6 months. So as they get older, we expect that this isn't going to happen maybe as pervasively. And the reason for that kind of harkens back to what Dr. Womack was speaking about earlier, and that is that kids are going to sometimes struggle with behaviors. We've all heard of terrible twos and terrible threes. Like that is a real thing. Kids do struggle in their development. They do go through those power struggles, learning boundaries, learning limitations, learning all of those things. And we don't want to diagnose or pathologize all of that, right? Because sometimes it is just normal development. And I think it is important for us to acknowledge that too. We don't want to over-diagnose these things either. And so it is really important to be thoughtful about what is typical for a kid of this age. Next slide, please. So when we're looking at the criteria, again, this is going back to that manual. We're looking at those behaviors that I talked about. And the first 3 that I've listed are in the angry and irritable mood piece, which is they're going to lose their temper. They're going to become touchy and easily annoyed, right? If somebody just bumps into them or says just the wrong thing, they're oftentimes angry and resentful. Next slide. And then that second part where they're argumentative, this is where they're arguing with authority figures, no matter what, parent, teacher, coach, doesn't matter. They're going to be argumentative with anybody of authority. They might oftentimes refuse requests or just not comply because they're not going to, because somebody that set a rule, they're just going to go against it because it's an authority figure giving that rule. And then oftentimes they might deliberately annoy others, and this is oftentimes with peers. And then they blame others. So they're never willing to take on their own mistakes. They want to put that on somebody else. And then the vindictiveness piece that we already talked about is that kind of last or 8th possible criteria. Next slide. And I think I repeated this again, and there was a reason because I wanted to focus on that last bullet. So we've already kind of talked about those top 3, but then this last bullet. The frequency and the areas in which these things occur is what helps us quantify this a little bit more, a little bit better. And so when we see oppositional defiant disorder occur in just one setting, so say only the home environment, we would consider that mild. If it's happening in two settings, that's moderate. Three settings, severe. And then if it's more than three settings, I think there's a profound as well, but that's pretty uncommon in kids. But so a lot of times we're going to be in the moderate to severe range, dependent on how many settings we're able to identify this in. And it is really helpful, I think, because there are some kids that do really well in school, but at home they really struggle with these types of behaviors, or other kids that do really well at home and only struggle in school. So it gives us a way to say, hey, they're actually doing well in most environments, but struggling in one versus those kids that are struggling in multiple settings. Next slide.
So our case is an 8-year-old that we're going to call Milo, referred by the school principal for behavior issues. And apparently he needed some stitches removed. Apparently he was playing with a bow saw and required 10 stitches. He had a nasty laceration on his right upper thigh. So even when I was seeing it all healed, it was pretty big. So talk about like, safety that Dr. Knudson had mentioned before. In his case, his symptomatology started at the age of 3, and you would assume that behaviors would get better with age, but in his case, they were getting worse. And his symptoms included emotional outbursts, really long tantrums that required a couple of times for the teacher to empty the classroom and just let him be there by himself for safety reasons. He was physically aggressive to his mother and his grandmother, especially when they tried to take away his video games. But the biggest thing that at least mom complained about is that she said that he woke up in the morning irritable and went to bed irritable and all in between. So she felt like she and grandma had to tiptoe around him all the time. He also apparently cursed a lot, particularly at home. Um, Pertinent history for him is that his mom and his grandma had moved with Milo to Nampa just recently from Alaska, where dad was still there because of obligations in the military. And dad had a history of anger issues and had yelled and threatened to hit Milo in the past, but according to Milo, never had. He also was being bullied in a school in Alaska, which is one of the impetus for mom to move from Alaska to Nampa. Um, and to the point where he was getting marked at school. The other thing that was pertinent in his history is that he had yet to learn how to read, and he was in second grade. Um, he spent the vast majority of time at home playing violent video games. His favorite was Fortnite. And unfortunately, he had started to get bullied at the school he had just started in Nampa. Next slide. So I'm just showing here a snippet from his parent Vanderbilt questionnaire. As you remember, the questions 1 through 18 are the diagnostic criteria for ADHD. Questions 19 through 26 on the parent Vanderbilt questionnaire are taken straight from the diagnostic criteria in the DSM-5 for ODD, or oppositional defiant disorder. And again, as you may remember, the number twos and number 2 is often, and number 3 means very often that these things were happening. And here are those diagnostic criteria: arguing, losing temper, actively defiant, and deliberately annoying, angry, resentful, spiteful, etc. And also in this case, I'm not showing it here, but he also met criteria for ADHD combined type. So similar to our prior case, we started counseling, and we got him a behavioral consultant to talk to mom and grandma about, at the very least, in terms of screen time, maybe not decreasing the amount of screen time, but at least changing the content so that it wasn't always violent video games. Maybe he would spend more time doing some educational content to help him with his literacy, things like that. Just being mindful that, for mom and grandma, it was hard. Mom worked full time, grandma had some disabilities. And so you can't just say, do this and think that people can change your lives completely. So they had a behavioral consultant work with them on some of those small tweaks to start some small successes for Milo. And he also was started on medication. And he has since moved to the East Coast, but mom actually communicated with me earlier this year saying that he had been doing quite well. So I was really pleased to get that follow up. So a note that for this case, I think is important is that, as with most things, things don't happen in a vacuum. Mental health diagnoses don't happen in a vacuum. Uh, like in this case, there was some potential anger issues on part of the dad. There was bullying. There was a recent move. He hadn't learned how to read. Is that because of a learning disorder? Or is it because nobody's been working with him? And if you can't read in second grade, how much is that going to make you pay attention in class? It must be super frustrating. So you have to take in all of those different factors while you're making a diagnosis and trying to help these kids. Next slide.
So now we're going to transition to disruptive mood dysregulation disorder, DMDD. This is kind of like oppositional defiant disorder on steroids, is kind of how I like to view it. And this is a disorder that is actually relatively new to psychiatry, to the DSM. It was birthed in the DSM-5, which is our current diagnostic manual, which came about in about 2013. And so prior to that, we did not have this diagnosis. The reason that it was thought to be beneficial in children is because there was concern about the overutilization or overuse of the diagnosis of pediatric bipolar disorder. And so they birthed this disorder kind of as an opportunity to kind of help identify some of these kids who are struggling with mood dysregulation, as the title suggests, but maybe weren't fitting the mold of true bipolar disorder. But as you can imagine, with oppositional defiant disorder, it can disrupt family life and peer relationships, oftentimes leads to poor school performance. And a lot of times, these kids are more at risk for dangerous behaviors and violent behaviors, and oftentimes even some suicidal behaviors, and require at times psychiatric hospitalization. So again, that's that kind of amplified piece that I was alluding to. We predominantly see it diagnosed in males, but I have plenty of females, biological females in my clinic who have this diagnosis as well. Um, the difference between this and bipolar disorder, or IED, which is intermittent explosive disorder, is that the irritability in these kiddos is not episodic. They present with chronic or persistent irritability. So one of the criteria is that they need to be irritable most of the time. They're like on edge irritable almost always, whereas like somebody who has intermittent explosive disorder might have an episode of irritability, but then they come back to baseline, and then they're kind of at that normalcy most of the time. Next slide, please. So the diagnostic criteria we'll just kind of review briefly, but they have severe recurrent temper tantrums, and these have to be really out of proportion with what has happened. So like, for example, their phone was taken away and they have this huge explosion that becomes violent, throwing things, hitting, whatever. These have to occur on average 3 or more times per week. So these kind of spikes, and then the rest of the time their mood between tantrums remains persistently irritable or angry. Even oftentimes kids with oppositional defiant disorder, in between they can be pretty pleasant and calm and decent to be around. These symptoms have to be present for at least 12 months. So we want to see this pattern over an extended period of time. We're really hesitant to diagnose it because a lot of times it can be defined through other things like ODD, and needs to be present in at least 2 settings: home, school, and with peers. We don't diagnose before the age of 6, and we do not diagnose this after the age of 18 either. And the onset of symptoms has to have occurred before the age of 10, not necessarily diagnosed before the age of 10. So it could have been something brewing over several years, but needs to have started before the age of 10. It cannot coexist with oppositional defiant disorder, with bipolar disorder, or intermittent explosive disorder. So if you say a kid has ODD and DMDD, DMD trumps ODD, so you just remove the ODD diagnosis. Next slide. A very simple case presentation. I'm keeping it simple because I know we're always tight on time. Is that, for example, there was a 9-year-old that was brought into my clinic several months ago by his parents for concerns of what they were referring to as this volatile mood and aggressive behaviors. And so whenever I hear aggression, that kind of piques things for me. And when we explored this a little bit, these volatile moods were occurring every day in the household, where this kiddo was very irrational and would just explode over the smallest thing. Somebody took something that was his. He wasn't served his food in just the right way. His parents told him to go to bed when he was finishing up with a round of whatever game he was playing. And so these behaviors just became explosive, and he became aggressive to the point that he was causing damage to property and being violent with others in the home. When I talked to him, he reported that I feel angry all the time, almost always. I very rarely feel calm or in control. In addition, he had been suspended from school for throwing a desk, not a chair, a desk at a peer who was making faces at him, right? So this was like not like a peer punched him in the face, but rather it was like somebody made a face and then he was like flipped the desk and came at this kid. And he had also broken his tablet at home when he was asked to turn the volume down. I said TV, that's the wrong word there. And so, how did we get at this, or what did we do for treatment in this case? Well, we obviously started some behavioral therapy. So, getting this kid involved in some behavioral interventions was an important piece to this. We also got him involved in talk therapy. So, just some regular CBT-based psychotherapy, giving him an outlet or an opportunity to vent some of these problems or challenges that he was experiencing. And then he was also started on medications. When you look at recommendations around medications, there's lots of things out there that exist. One, a lot of common treatment around this involves use of alpha agonists, which is what Dr. Womack was referring to with guanfacine that was used in the past case. And sometimes, if the violence is severe enough, we might use medications like antipsychotics or antiepileptics, things like Abilify or Risperdal or Lamictal, and other medications like that. And won't get into all the details of that because we'd be here forever. So next slide. Now transitioning to depression. So when we're looking at depression in youth, the lifetime prevalence, first of all, is approximately 17%. It really is now approaching about 20%. So we like to say, or we often will say 1 in 5. So 1 in 5 of our youth are struggling with depression, with the prevalence of biological females being about 1.1 to 1 when compared to their biological male counterparts. 4% of children in the ages of 3 to 17 had current diagnosed depression, double in biological females compared to biological males, which suggests that this is oftentimes not coming out or manifesting or being diagnosed, maybe when it could be or should be. And then among children with depression, approximately 79% receive treatment, compared to 59% of children with anxiety or 52% of kids with behavioral disorders. This has been reassuring data that's come out recently that suggests that kids with depression are being caught more often nowadays and that they are actually seeking treatment. These numbers used to be right around 50%. And so we are definitely seeing an uptrend of this being identified and diagnosed, which is again reassuring. That 17% is symptoms of depression in the last 2 weeks. Next slide. So when we talk about depressive disorders, there's many that exist. We're going to go through a few of these very quickly, but this is just kind of a list of the different ways that depression can present. Next slide. The first, of course, is major depressive disorder. This is the most commonly diagnosed in kids, and the diagnostic criteria exists here in this blue box, which we refer to as SIGI CAPS. That's kind of our acronym or way to remember these things. But and you can see right there on the list the different areas what might be impacted because of depression: sleep, energy levels, concentration and focus, harkening back to what Dr. Womack was saying, that we need to be screening for depression, anxiety when we have kids who are struggling with focus. Their appetite can be impacted, and then suicidal thoughts is another thing that we sometimes see in individuals who are depressed. One thing to point out is that with kiddos, uh, there are two things that we require, or one of two things: either anhedonia, which means a decreased interest in pleasurable activities, or dysphoria, which means depressed mood. We replace that in children and adolescents at times with irritable mood rather than what they would identify as sad mood or classically depressed mood. So if they've seen a shift in mood, but it's not necessarily sad, but irritable, we will allow that in the diagnostic criteria of depression. Next slide. Here's our friend Eeyore, and this is persistent depressive disorder. So this is the exact same as major depressive disorder, but symptoms have to be present for 2 years in adults, 1 year in children and adolescents. And what we say is, in order for that to be persistent, there needs to be a pretty consistent pattern without a break of greater than 2 weeks. And so it really is going to be very pervasive and present. They might have occasional up moments, but most of the time they sit low. Next slide. PMDD, or premenstrual dysphoric disorder, or depressive disorder, is a condition that is seen in biological females and is directly correlated to menses or their periods. And so what we know is with females, they have various hormonal surges throughout a menstrual cycle. And as a consequence of that, some individuals will experience depressive symptoms the week prior to and the week of menses. And so they'll experience kind of this cyclical pattern of depression that gets worse over that week leading up to and then the week of menses, and then improves or returns back to baseline. We could again spend a ton of time talking about the treatment of that, but the way to combat that is either through the use of birth control or adjusting the basal dose of medication that they're prescribed maybe at baseline. Next slide. Substance-induced depressive disorder is a real thing, and unfortunately, we're seeing the use of substances way more commonly in our youth than ever before. And so, especially downers are things that we need to be looking out for. So that's nicotine, alcohol, cannabis are probably our three leading causes of substance-induced depression. Also, opioids are a big downer. So individuals who might be abusing painkillers or pain medications can also experience a lot of depression. On the other hand, even individuals who are misusing or abusing uppers like stimulants, cocaine, will have highs, but the crash afterwards is pretty intense. And so we will see those kids also present with depressive symptoms. Point being, if they're using substances, it's impossible to know if this is a true mood disorder or if it's related to the substance. So we need to make sure we're screening for and ruling that out with our kids. Next slide. And then we never want to forget about medical conditions, because medical conditions do oftentimes appear as mental health conditions. And so anytime we have a kiddo that presents to clinic with a depressive episode, we want to make sure we're doing our due diligence and ruling out medical causes that could be contributing to this. So I've just listed a few of those things and various labs or tests that we can do to evaluate those types of things. For example, individuals who struggle with glucose control in the form of hypoglycemia or diabetes can really experience fluctuations in their mood. Hypothyroidism, so individuals who have low thyroid can really struggle with symptoms that look like depression because they're sluggish, they're fatigued, they're gaining weight, their appetite's all over the place. They feel blue, they feel sad as a consequence of that. And so I won't spend time going over all those things, but it's just important to remember that medical conditions can mask all of these things, not just depression, but all of these things. Next slide.
Yeah, so our next case is a 15-year-old female and was actually referred by the school nurse for nausea and abdominal pain that wasn't necessarily causing absences, but causing her to leave school early. But it was almost every day that she would show up at the school nurse's office after calling her mom multiple times, and so she always ended up leaving school early. When I saw them in clinic, I learned that this student hadn't been attending school at all, had been doing online school for 4 years, and had just started attending school that fall. And that there was a recent, since the beginning of school, 10-pound weight loss. So over a period of like 2.5 months, had lost 10 pounds. Um, it was important, especially with the 10-pound weight loss. Like Dr. Knudson said, okay, what's going on? Is there anemia? Is there diabetes? We had to really get a careful history to rule out any medical condition, especially with the nausea and abdominal pain. So as part of the workup, we did do a PHQ-9. I'm sure most of you are now aware of what a PHQ-9 is because of the unfortunate recent spate of suicides in adolescents in the Boise and Annapolis school districts. So there's been an uptick in screening with PHQ-9. So that's our depression screening. It stands for Patient Health Questionnaire. There's 9 questions, and the scoring is from 0 to 27. And this patient scored 22, which puts them in the severe range for depression. We also did a Columbia screen, which is a screen for suicidal ideation. And thankfully, at the time that we saw her, she was low risk for that. So she actually did get quite a workup, first with pediatric GI, and then was seen in the adolescent clinic, which was formerly known as the eating disorder clinic. And she ended up getting a diagnosis of abdominal pain due to constipation, and diagnoses of both depression and eating disorder. Um, she started counseling, and she was actually quite articulate, which made her a really excellent candidate for counseling. And I'm happy to report that she regained the weight. She's still being followed by the adolescent clinic. But what I was really impressed with was at her school, she was getting daily check-ins. So what that means, well, I don't have to tell the school nurses this, but usually it means that once a day at a certain time, somebody in the school, it could be a school nurse, school counselor, a vice principal, checks in with that patient, sits them down somewhere alone, sometimes just during passing period, looks them in the eye and says, "How are you doing today? Have you been since yesterday? Uh, tell me what's going on. What are you feeling?" And when students have something like that, they have a daily check-in, it's almost like a security blanket. They know it's going to happen. There's going to be that one time they can talk to a trusted adult about how they're feeling, and it really makes a huge difference. So this student who had been missing so much school, they did the check-in kind of later in the day on purpose, and she started being able to attend school till the end of the school day way more often from that simple intervention. And then another note about this particular case is that many mental health diagnoses present with physical complaints, just like this one did. And again, vice versa. So you can't just dismiss nausea and abdominal pain just because someone has a high PHQ-9, right? You have to get that thorough history and physical. Next slide.
All right. So our last topic of the day is anxiety disorders. And I know we've got about probably 7 or 8 minutes left. And so we will probably just get through anxiety disorders and save some of our interventions for our next session. So you can wait with bated breath for that. But um, in talking about anxiety disorders, there are a few I think that are important to highlight. And there's more than what I'm going to mention today, but I think just a few things that are really important to touch base on is generalized anxiety disorder, which is the most common. And then, of course, in our adolescent population, we see a lot of social anxiety disorder and panic disorder and obsessive compulsive disorder. This is very, very, very common in youth, including types that we're not going to think as much about with adults. Um, they tend to travel in packs, I like to say, anxiety disorders. And so the most common comorbidity of one disorder is another anxiety disorder. So a lot of times a kid has generalized anxiety disorder, social anxiety disorder, and something else that's anxiety related. And so it can oftentimes manifest in multiple settings. OCD is really important to watch out for, and I think it's missed, unfortunately, a lot. But this is a disorder that begins in childhood with the most common time of diagnosis around the ages of 9 and 11. And so I rounded it to 10, but 9 to 11 is when this most commonly occurs. And it oftentimes can co-occur with tic disorders and ADHD as well. Something else we always want to consider when a kid presents with anxiety disorders is whether or not this is secondary to trauma or whether or not this is secondary to ADHD. And so that those things can sometimes present with anxious distress when something else might be going on. Next slide. So with generalized anxiety disorder, kids, it's really easy for them to meet criteria here, I have to say. And so kids oftentimes do meet criteria for generalized anxiety disorder. They have to have anxiety and worry for at least um, one of the symptoms below for kids. For adults, it's three or more, but kids, it has to be just only one of those. So it can be pretty easily met. But that's like being restlessness or feeling on edge. They might be easily fatigued. They might struggle with difficulty concentrating, that irritability, muscle tension, sleep disturbance. But it has to be worry that is identified as excessive in nature and remember, causing distress and functional impairment. That is always important for diagnosis. Next slide. A few other anxiety disorders that I think we want to consider is social anxiety disorder. So this is an individual who's going to really struggle with maybe some symptoms of generalized anxiety disorder, but also struggles with interpersonal relationships. They're spending a lot of time wondering, did I say the right thing to that friend? Oh, I wish I wouldn't have said that. Why did I do that? Why did I text this? Oh, that was so stupid. They're constantly worried about being judged by others, thinking others are whispering about them, talking about them behind their back, worried about how they appear, worrying about saying things in public because they might say something that's embarrassing to them, worrying about being approached by somebody they don't know and what would I say. So those are ways that this commonly manifests in adolescence in particular. Then there's panic disorder, which is like anxiety with physical symptoms. So it's going to be chest tightness, can't breathe, sweating, shaking, etc. So it can present in a number of those ways. Individuals can be selectively mute, which is where they don't talk in only specific settings. Usually at home, they're fine. When they're with parents, siblings, they're talking normally. Then they get to a doctor's office, school, they all of a sudden do not speak at all. And then separation anxiety disorder are going to be kids who are older than usually like that 3, 4, beyond the stranger danger phase, and they're struggling with being apart from usually primary caregivers. And the fear a lot of times with that is that they're fearful that something bad is going to happen to their primary caregivers that will cause them not to return. So they're going to get into a car accident. So they're going to leave me. Something bad is going to happen. And that fear of separation can become really strong. Next slide.
So we have our last case, 14-year-old male who presented to our clinic. A school nurse referred for pretty frequent chest pain and difficulty breathing at rest. By the time I saw him, he had missed more school than he had attended that semester. He had a workup in the emergency department in the summer before school had started, and it was essentially negative. He had a normal chest X-ray and a normal EKG. Pertinent history is that he and his mom and his stepdad had emigrated from Colombia 13 months prior. And his stepdad was someone that he didn't really get along with. So really his only person was his mother. And he readily admitted that he was worried that if he lost her, he would lose what he said everything. So, his just his entire past. I mean, he's in his whole new country. He's lost his culture. He's lost his language. He lost his friends, and then he was just panicked that he was going to lose his mom. And so when he complained of chest pain and difficulty breathing at school, and mom was called, mom was had the very same kind of uh, emotions as he did, and was worried about losing him. And so, of course, she said, yes, please send him home. And then, oftentimes, if he complained of chest pain or anything in the morning, she just wouldn't send him to school. He wasn't sleeping well because of these concerns about his mom. And as we all know, if you're not sleeping well, nothing goes well. Everything is, all the negatives are exacerbated. And of course, learning is more difficult, and being able to adapt to new situations, goes by the wayside. So, when we saw him in clinic, we administered the GAD-7 and the SCARED questionnaires. These are two screenings we use for anxiety. The GAD-7 is to anxiety, like the PHQ-9 is for depression. So the GAD-7, GAD stands for Generalized Anxiety Disorder. There are 7 questions. And that's even though there are only 7 questions, it's pretty validated. The SCARED questionnaire, the SCARED stands for Screen for Child Anxiety Related Emotional Disorders. That actually has 41 questions. It has a parent and a child version. And the reason I like the SCARED questionnaire is because it goes all the way down to 8 years of age. Of course, when they're that young, you have to help the patient with the questionnaire, but it is validated all the way down to 8. So he had very high scores on both of those questionnaires. And just like Dr. Knudson said, that anxiety disorder, most common comorbidity is another anxiety disorder. He met criteria for generalized anxiety disorder and separation anxiety disorder, and probably mom as well, though I don't diagnose adults. So because the school did such a good job with him, we did not start him on any medications. He got enrolled in an English as a second language group of peers. He also had check-ins with the school nurse. We told mom the importance of not doing school avoidance. We don't have time to get into it today, but when it comes to anxiety, avoidance is the worst thing you can do. So we worked really hard on making a schedule where he would stay in school for a certain amount of time. He'd always go to school, no matter how he was feeling, do the check-in with the school nurse, and then gradually kind of work him up to yeah, staying in school for the entire school day. And also happy to report that he's overall doing okay. He still struggles, but I think with time he's improved, and with some education on the part of mom in the importance of going to school. Next slide.
All right. Well, I think we will wrap that up for today, and we'll add these last few slides onto our next presentation. But thank you for your time. I maybe have a minute or two for questions, but I think I won't speak to that. But if you guys do have questions, you are always welcome to message us or email us, and we are happy to answer those questions on the site as well.